Hello everyone, welcome to this lecture series on rheumatology, and in this video we will be studying systemic sclerosis. To start off, systemic sclerosis is an autoimmune condition and it is an orphan disease with unknown etiology. So, what this means is that the condition is so extremely rare that it is not profitable enough for big pharmaceutical companies to find novel therapies and treatment strategies for systemic sclerosis. So, if someone is unlucky enough to develop systemic sclerosis, then they are stuck with it since the current management is not really effective, as we will see later on. So, it is an acquired autoimmune disease with progressive course and variable clinical presentation, which can involve any organ, right? Hence the term systemic in the name itself. SSC mostly affects 50 to 60-year-old age group people and with a female preponderance, as is the case with all other autoimmune conditions. The female to male ratio is about 4:1, right? Now, systemic sclerosis is mainly a sporadic condition, right? This is an important point. There is genetic predisposition, but the genetic associations are relatively modest compared to other autoimmune conditions. Hence, systemic sclerosis is more of a sporadic condition rather than an inherited one. Alright, moving on to the broad classification, it is done based on whether the systemic features are present or absent. So, the thickening and induration of skin is known as scleroderma, right? But if systemic features are present along with scleroderma, only then the condition is termed as systemic sclerosis, which again can be divided into diffuse cutaneous systemic sclerosis or limited cutaneous systemic sclerosis. If the systemic features are absent and the disease is limited only to the skin involvement, then the condition is known as localized scleroderma or morphia. Right, this we will cover in dermatology, and the current video of ours will be limited to the discussion of systemic sclerosis. So now we will differentiate between the diffuse cutaneous variant and the limited cutaneous variant of systemic sclerosis. LCSSC was earlier also known as CREST syndrome, which itself is a mnemonic where C stands for calcinosis cutis, R for Raynaud's phenomenon, E for esophageal dysmotility, S for sclerodactyly, and T for telangiectasia. Right, so this CREST mnemonic will help us differentiate DCSSC from LCSSC. Okay, so as you can see here, this is the table showing frequency of clinical organ involvement in systemic sclerosis. So as you can see here, calcinosis cutis, Raynaud's phenomenon, and ischemic digital ulcers, which again are a complication of Raynaud's phenomenon, esophageal involvement. So these features you will find that are more frequent in limited cutaneous variant. So basically these the crest features are more common in limited cutaneous variant, right? That's the gist of it. The skin involvement, as you can see, is seen in both limited and diffuse variant, although 10% cases of limited cutaneous variant have SSC sign scleroderma. So this is a special condition in which there is Raynaud phenomenon and other characteristic clinical and lab features of systemic sclerosis, although without any detectable skin thickening, right? So this is a special condition. Apart from that, all features of crest are more common in limited version compared from diffuse variant. With diffuse variant will have more features like interstitial lung disease, myopathy, clinical cardiac involvement, renal crisis. So these will be more common in diffuse variant, while the crest features are more frequent in limited variant, right? Then another point is that diffuse cutaneous systemic sclerosis in general has earlier onset and severe involvement, right? As you can see here, skin involvement, diffuse variant has rapid onset, diffuse involvement, and rapid progression. Even musculoskeletal system, we have severe arthralgias, ILD is frequent and severe. PAH is also common here. Renal crisis also occurs in 15% cases. So diffuse cutaneous variant of systemic sclerosis has in general earlier onset of clinical symptoms and severe involvement compared to limited cutaneous variant where there is indolent onset and slow progression, and the disease is mild in general, right? Except two features, the calcinosis cutis and Raynaud's phenomenon. These are more common and more prominent in the limited cutaneous variant. So once again, the CREST mnemonics we have, from that comes the CR, right? The calcinosis cutis and Raynaud's phenomenon are more prominent in limited cutaneous. All other features are more severe in diffuse variant, right? So this is the basic difference between limited cutaneous and diffuse cutaneous variant of systemic sclerosis, and this completes the first part of our discussion. Alright, so now let's begin with the second section, the pathophysiology of systemic sclerosis. So, three cardinal processes underlie systemic sclerosis, which are the diffuse microangiopathy or vascular injury, immune dysregulation, which comprises of inflammation and autoimmunity, and visceral and vascular fibrosis. So, microangiopathy, immune dysregulation, and fibrosis are the three underlying processes. In general, vascular injury and autoimmunity are early features, whereas fibrosis or organ atrophy occur later in the disease. Right, so this is an important point. So, let's take a look at let's take a look at this figure which shows the sequence of events. So what happens is there is an initial vascular injury which triggers this whole cascade of response. The initial vascular injury is followed by an immune system response which normally clears the cellular debris and leads to healing of the lesion, and that's it. But what happens in systemic sclerosis is this system response is quite extensive and leads to extensive inflammation and release of fibrotic signals, leading to tissue fibrosis. So, tissue fibrosis is the end result, which ultimately leads to architectural disruption, which can manifest as pulmonary fibrosis, renal fibrosis, heart failure, GIT dysmotility, tendon friction rub, joint contracture, etc., depending on the organ where initial vascular insult was seen. Right, there's also an alternate pathway where due to impaired vasculogenesis we have microangiopathy, where we can see leaky blood vessels, fibroproliferative arterial lesions, etc. This in turn leads to tissue hypoxia, which further leads to inflammatory and fibrotic cellular responses, further ending up in tissue fibrosis. Tissue fibrosis itself causes tissue hypoxia and perpetuates this vicious cycle where pre-existing tissue fibrosis leads to further fibrotic cellular response. So this flow chart in general summarizes the pathogenetic mechanism of systemic sclerosis. There's also a role for the autoantibodies, which we will see just a bit later. The list of all the important autoantibodies in systemic sclerosis. First, let's take a look at the potential risk factors. So, exposure to drugs like bleomycin, pentazocin, and exposure to toxins like particulate silica, PVC, aromatic hydrocarbons, epoxy resins, even exposure to viral agents like Epstein-Barr virus, cytomegalovirus, parvovirus B19 can be a potential risk factor for development of systemic sclerosis. Of course, there is a genetic predisposition as well. We can add it here as one of the risk factor for systemic sclerosis. All right. Now, on histopath examination of the fibrotic tissues, initially you will see a lot of inflammation, and in later stages there is extensive collagen deposition leading to tissue fibrosis. There might be pockets of inflammatory cell infiltrates, neutrophil accumulation, but the overall picture is of extensive collagen deposition and fibrosis. Right. Now, coming on to the important autoantibodies in systemic sclerosis. So the most important autoantibodies are of course the ANA or the anti-nuclear antibodies. These are the most sensitive autoantibodies for SSC and thus the best screening test for systemic sclerosis. Anti-topoisomerase and anti-centromere are best for diagnosis. They are best for confirming the diagnosis of systemic sclerosis, since anti-topoisomerase 1, also known as anti-SCL70, is specific for diffuse cutaneous systemic sclerosis, while anti-centromere is specific for limited cutaneous systemic sclerosis. Alright, then we have anti-RNA polymerase 3, which is associated with an increased risk of renal crisis and malignancy in systemic sclerosis patients. Anti-U3RNP or anti-fibrillary, which is associated with an increased risk of renal crisis and lung involvement like interstitial lung disease and pulmonary artery hypertension. So this is a table from Harrison's which shows a list of all the antibodies which we have already covered: topoisomerase 1, DCSSC, centromere, LCSSC, RNA polymerase, cancers and cancers and ulceration and renal crisis, right? U3RNP, as we talked about, PAH and ILD, renal crisis. Then anti-U1RNP is associated with mixed connective tissue disease, right? So these are all the important antibodies. Basically remember these four which are important from the exam point of view. All right, so this covers the second section. All right, so let's begin with the clinical manifestations of systemic sclerosis. So skin is the most common skin involvement is the most common manifestation of systemic sclerosis, and it starts with non-pitting edema or puffiness of hands and feet which is the earliest cutaneous manifestation, right? Non-pitting edema or puffiness, and it later evolves into indurated, stiff, and shiny skin, which is also known as binding down, right? And if this occurs in digits like fingers and toes, then this binding down is what is known as sclerodactyly, which is a very classical feature of systemic sclerosis, right? Binding down begins in acral parts, and it might lead to contractures, and then it progresses proximally, involving the face, neck, and in diffuse cutaneous variant also the trunk, right? So sclerodactyly, as you can see here, this you can see the skin is very stiff and appears very stiff and tight, and it is appearing shiny, right? So this is what is known as sclerodactyly, right? Then apart from sclerodactyly, other skin changes are mask-like expressionless face, beaked nose, microstomia, microkelia with perioral radio furrowing, right? Furrowing, right? So this image shows microstomia basically means small mouth, and microkelia means small lips. So as you can see, the lips of this person are relatively thin and smaller as compared to a normal person's lips, right? And there is also these furrows which are going radially outwards, right? So this image is what is showing this microcalia with perioral radial furrowing, right? Then there can also be telangiectasia, which can be periangual, which means adjacent to the nail bed. Then facial mat-like telangiectasia, palmar telangiectasia. What is mat-like telangiectasia? It is basically a network of telangiectasia which are adjoined together. So as a whole, it gives a mat-like appearance of multiple connected red erythematous red colored telangiectasia. So that appearance is what is known as a mat-like telangiectasia, typically seen on the face of SSC patients. Then you can also have calcinosis cutis, which is basically calcium deposition in the digits and which appears like bumps, right? So calcinosis cutis, telangiectasia, and expressionless face, microstomia, microcalia, perioral radio furrowing. So these are the classical manifestations of skin, apart from sclerodactyly, of course, right? So right there, here you can see the mask like expressionless face. Then there is microstomia and microcalia, right? The mouth opening is small, and also the lips are very thin and narrow, right? So this is known as microcalia. And then you can see that telangiectatic blood vessels on the neck, right? Multiple telangiectasia, in fact, red colored, you can see these small, right? So this is the typical presentation. Then second, we have the Raynaud's phenomenon, right? So this is the most common extracutaneous manifestation of systemic sclerosis, right? Most common is skin involvement, sclerodactyly, and earliest is sclerodactyly, but the most common extracutaneous manifestation is Raynaud's phenomenon, right? And what happens, and what is Raynaud's phenomenon? Actually, it is basically a reversible, right? So this is important, reversible episodic vasoconstriction in the fingers and toes. It can also affect tip of nose and earlobes, but it most commonly affects the fingers and toes, and it is triggered by a decrease in temperature as well as emotional stress and vibration. Hence, can be also seen in workers using vibrating machines, tools, right? So it is most importantly reversible vasoconstriction, most commonly in fingers and toes, and again most commonly triggered by a decrease in temperature, right? What the question will ask you about the sequence of changes in Raynaud's phenomenon, right? So this is important. So first off, there is vasoconstriction, which leads to pallor. Then due to vasoconstriction, there is ischemia, lack of oxygenated blood supply, which leads to cyanosis. And then finally, since the whole thing is reversible, right? So there is, after some time, there is reperfusion, right? The blood vessels allow reperfusion, which leads to redness or hyperemia. Thus, the sequence is you can remember by the mnemonic PCR, where first there is pallor due to vasoconstriction, then cyanosis due to ischemia, and finally redness due to reperfusion, right? So PCR, this is the mnemonic for Raynaud's phenomenon. Then Raynaud's phenomenon episode is associated with pain and numbness in the affected limb. Of course, when the blood supply is impaired, there will be pain and numbness. Then Raynaud's phenomenon can be of two types. So if it can be a primary Raynaud's phenomenon, which is idiopathic, called as Raynaud's disease, and it can be secondary Raynaud's phenomenon due to an underlying autoimmune etiology, right? So primary Raynaud's phenomenon is basically an exaggerated physiologic vasomotor response to cold, right? Exaggerated response है basically वो. So the prevalence in general population is up to 5%, so it's quite prevalent in even the general population. Here we will see the characteristic features and differences in primary versus secondary Raynaud's. So primary Raynaud's primarily affects young women under the age of 30 years, and there is no underlying cause, right? It is idiopathic, and there is positive family history of similar Raynaud's phenomenon condition in the family, and ANA is negative because there is no underlying autoimmune etiology. Compare it from secondary Raynaud's, where it mostly affects older women older than 30 years of age, and there is an underlying autoimmune condition like Scleroderma, Sjogren's syndrome, and even SLE, and there is no family history, and ANA test is positive. Why? Because there is an underlying autoimmune condition, so ANA will be positive. Next up, primary Raynaud's phenomenon is less severe and is not associated with complications like digital necrosis, ulceration, and gangrene. Right, while secondary Raynaud's is more severe and is associated with complications like digital tissue necrosis, ulceration, and gangrene. Also, primary Raynaud's will have normal nail fold capillaryscopy, right? Normal capillaries and evenly spaced parallel loops, while in secondary Raynaud's there will be distorted capillaries with widened and irregular loops. Basically, nail fold capillaroscopy will be abnormal. So these are the differences in primary and secondary Raynaud's. Then okay, so this is the image which shows you the nail fold capillaroscopy. So as you can see, that in the normal pattern there are hairpin like blood vessels, right? So these hairpin like blood vessels, and they are all arranged in a parallel way and spaced symmetrically from each other. So this is the normal pattern, and these early, active, late are the disease patterns. So as you can see, there is no symmetry, and in early pattern you can see that there is a dilation of microvessels and symmetrically increased microvessels, giant capillaries. So these dilated giant capillaries you can see. In active pattern you can also see giant capillaries along with capillaries collapse with microhemorrhages and loss of capillaries. So there, as you can see, there are no capillaries in this region, so there is loss of capillaries, there is microhemorrhages, and there are giant capillaries also present. In late pattern you can see there is total collapse of capillaries along with fibrosis. Also there is neoangiogenesis, formation of new blood vessels, and these new blood vessels also have dilations. These are the secondary dilations, right? So this much specific detail is not required, just have a broad understanding. In normal pattern we have hairpin shaped blood vessel loops which are symmetrically placed parallel to each other, as compared to early active or late, which these are the diseased patterns where the symmetry is lost and the blood vessels may be dilated and even collapsed with microhemorrhages, right? So this question can be asked directly from this diagram, so have an understanding of this figure. Then causes of Raynaud's, as we studied, primary or idiopathic, and secondary Raynaud's can be due to a plethora of causes like collagen vascular disease, basically the autoimmune connective tissue diseases, scleroderma, SLE, rheumatoid arthritis. Then arterial occlusive diseases like atherosclerosis, thromboangiitis obliterans, pulmonary hypertension, neurologic disorders, blood disorders, trauma, especially vibration injury, right? So remember this. That's why Raynaud's can be seen in factory workers, piano players. Then drugs and toxins, ergot derivatives, bleomycin, vinblastine, right? So I have a broad understanding of what all these causes can be associated with secondary Raynaud's phenomenon, right? Then treatment for Raynaud's phenomenon, we have for primary Raynaud's phenomenon we can use vasodilators or alpha blockers like prazosin, terazosin, and vasodilators we have DHP, dihydropyridine calcium channel blockers, liltiazem. Then in secondary Raynaud's phenomenon you can have PDE5 inhibitors like sildenafil, tadalafil. Finally, if the patient is unresponsive to medical therapy, we go for digital sympathectomy, basically removal of the sympathetic nerve supply of the digits, right? So this completes the Raynaud's phenomenon for us. Now, pulmonary manifestation of systemic sclerosis is most common is interstitial lung disease, and what pattern of illness? NSIP, non-specific interstitial pneumonia. NSIP pattern is seen in systemic sclerosis. Compare from SLE, where we studied that UYP pattern was the most common pattern of ILD in SLE patients, right? Also, pulmonary artery hypertension can occur associated with systemic sclerosis, and it is the most common cause of death in systemic sclerosis. So this is a very important point. And PAH is more, although it is equally associated with the limited cutaneous or diffuse cutaneous variant, but if a question is asked, then remember that it is more common in limited cutaneous variant of systemic sclerosis. And PAH is in fact the most common cause of death in systemic sclerosis overall. All right, then we have the GI manifestations of systemic sclerosis. So it can affect basically at different levels, from oropharynx, esophagus, stomach. Oropharynx, we have diminished oral aperture, dry mouth, gingivitis, swallowing difficulty. In esophagus, there can be strictures, right, reflux and dysphagia. In stomach, remember GAVE, right, gastric antral vascular ectasia. So basically this has a watermelon stomach appearance on GI endoscopy, right. So GAVE is an important manifestation in systemic sclerosis. In intestines, you can have small intestinal bacterial overgrowth, SIBO. Then there can be general manifestations like diarrhea, constipation, obstruction, malabsorption, pseudo obstruction, right. In anorectum, there can be sphincter incompetence, right. So these are the GI manifestations. Then yeah, in renal we have, yeah, this is very important, scleroderma renal crisis. So this is quite an important manifestation in systemic sclerosis patients. It can be seen in up to 15% of systemic sclerosis patient, mostly in diffuse cutaneous variant of systemic sclerosis, right. And what happens here, there is basically accelerated hypertension accompanied by acute kidney injury and progressive renal failure, right. On pathological biopsy picture, you will see that the patient has acute fibrinoid necrosis of afferent arterioles, along with the onion skin proliferation or onion skin pattern of fibrosis and ischemic collapse of the glomeruli. Right, so acute fibrinoid necrosis, onion scale intimal fibrosis, and ischemic collapse. These changes, where else we can see these changes? These changes we also see in thrombotic microangiopathy like HUS and TTP, right? So same picture is seen here as well, and just like TMAs like HUS and TTP are accompanied by thrombosis, thrombocytopenia, and hemolytic anemia. Here also you will see thrombosis, thrombocytopenia, and intravascular hemolysis, and there might be evidence of complement activation in the kidney biopsies, right. So remember scleroderma renal crisis, right, seen in up to 15% patients, and aka in progressive renal failure along with accelerated hypertension. Then cardiac involvement is mostly silent, right. So not really much involved in early course of the disease. In musculoskeletal complaints, patient will mostly have carpal tunnel syndrome, generalized arthralgia and joint stiffness, joint contracture, tendon friction rubs. Then on joint imaging, you will see synovitis, right, and muscle weakness, acroosteolysis. So just remember these things. There's nothing to much nothing much to understand here. Uh, just do a superficial read. In other manifestation, we have dry eyes, dry mouth, Sicca complex, just like Sjogren syndrome, fibrotic salivary glands, hypothyroidism, erectile dysfunction. CNS is not affected in systemic sclerosis, but uh, sensory trigeminal neuropathy can occur, right. Fertility is not affected, but high risk to fetus in pregnancy, increased cancer risk like lung cancer, esophageal adenocarcinoma, breast cancer, ovarian cancer, right. So increased cancer risk is an important aspect of systemic sclerosis. So this completes the clinical manifestations of SSC. All right, so now let's move on to the next topic, the diagnostic criteria for systemic sclerosis. So we have the ACR EULAR criteria here, right? And the cutoff score that is required to diagnose systemic sclerosis is more than equal to 9, right? So there are multiple criteria and sub-criteria here with different weights or scores. Now, no need to remember all these, just remember that bilateral skin thickening which is extending proximal to the metacarpophalangeal joint, it single-handedly carries a score of 9. That means this is a pathognomonic finding for systemic sclerosis, right. Rest all findings have different weights, and a combination of these will help us to come at a clear-cut diagnosis. Then moving on to the management of systemic sclerosis. So A peculiar point regarding this condition is that steroid-sparing immunomodulators have modest to no benefit in systemic sclerosis, right? For example, methotrexate, calcineurin inhibitors like cyclosporin, azathioprine, 6-mercaptopurine. So these sort of drugs have modest or little benefit in systemic sclerosis most of the times, and even steroids are helpful only in the early inflammatory stage of disease. They help prevent stiffness and aching, but they do not prevent the progression of systemic illness, right? Hence, steroids also are given only in short doses for short intervals and are stopped as soon as possible so as to prevent systemic toxicity due to steroids, right? So, all in all, steroids and immunomodulators are not really much helpful in controlling the progression of systemic sclerosis as compared to their effectiveness in other autoimmune conditions like SLE, etc. Right? So, in systemic sclerosis, the usual therapy is individualized based on what sort of presentation patient has. We decide the therapy. Now, we don't need to remember all the drugs and based on what symptom patient presents. Just remember 2-3 important points that if the patient presents with interstitial lung disease, then cyclophosphamide is the drug of choice to reduce progression of lung disease. Then bosentan is the drug of choice to reduce the risk of new ulcer and Raynaud's phenomenon if the patient complains of severe Raynaud's phenomenon leading to digital ulcers and digital tissue necrosis, right? Similarly, drug of choice for scleroderma renal crisis is ACE inhibitors. So this is also an important point. I guess it has been asked previously in INI-CET if I'm not wrong. So these are 2-3 important drugs which you have to remember, right? Then prognosis, markers of poor prognosis, male gender, African American race, older age at onset. So these are all you have to remember. These are commonsensical, that extensive skin thickening, palpable tendon friction rubs, evidence of significant progressive visceral organ involvement are obviously markers of poor prognosis, right? Similarly, lab predictors of increased mortality at initial evaluation include elevated ESR, anemia, proteinuria, and anti-topoisomerase antibodies. Right. The last topic which we have in this discussion is scleroderma mimics. Right. So there are certain conditions associated with skin duration. Of course, systemic sclerosis and localized scleroderma, which is called as morphia, are two of the most peculiar conditions. Apart from these two conditions, there are multiple other conditions which have this clinical presentations. Right, like pansclerotic morphia, overlap syndromes, diabetic scleroderma, scleromyxedema, chronic GVHD, eosinophilic fasciitis, paraneoplastic syndrome, chemical and drug associated scleroderma mimics. So there are a whole sort of other conditions which mimic this presentation. So we will be covering 3 of these conditions which are important as far as our discussion is concerned. First is the mixed connective tissue disease. Which is a type of overlap syndrome, right? Overlap syndrome means a condition in which there is an overlap of symptoms of two connective tissue disorders, right? So mixed connective tissue disease is a type of overlap syndrome in which patients with limited cutaneous systemic sclerosis have coexisting features of SLE or polymyositis, dermatomyositis, and or even rheumatoid arthritis, right? So SLE, polymyositis, dermatomyositis, rheumatoid arthritis plus limited cutaneous variant of systemic sclerosis. So overlap of these connective tissue disorders constitute a patient with mixed connective tissue disease. Now, this is an important point that the characteristic autoantibody is anti-U1-RNP, right? And absence of SSC specific antibodies, even though patient has features of limited cutaneous systemic sclerosis. So you would expect anti-centromere antibody to be positive, but it is absent, right? Instead, anti-U1-RNP is present in MCTD. Next, chemical and drug induced scleroderma like conditions. Okay, so in just you can see this table at polyvinyl chloride induced disease. Then we have eosinophilia myalgia syndrome with L-tryptophan contaminant exposure, nephrogenic systemic fibrosis due to gadolinium contrast exposure, right? So these are some chemical and drug induced scleroderma mimics. Finally, eosinophilic fasciitis, a rare idiopathic disorder of adults, right, associated with abrupt skin duration. And okay, the characteristic feature of this is cobblestone pewed orange appearance of skin. So where else have we studied POD orange appearance? We have studied it in inflammatory breast carcinoma, right? So whenever we see POD orange in a question, we remember what inflammatory breast carcinoma. But if the question has no mention of breast cancer or anything related to breast, and still you see POD orange, then what should come to your mind? Eosinophilic fasciitis, right? So this can occur in association with preceding myelodysplastic syndromes, multiple myeloma. Biopsy will show fibrosis, eosinophilic infiltration, even peripheral blood eosinophilia can be present in acute phase. Treatment is steroids. So just remember this point: cobblestone, POD orange appearance of skin, which is characteristic for eosinophilic fasciitis. So that completes our discussion on systemic sclerosis. Thanks for watching and see you in the next one.